So if you've got hip osteoarthritis, or your hips are really stiff, they really hurt, and they're stopping you do things at night and in the daytime, or you're really curious about the Röttinger hip replacement, then this video is absolutely for you. I'm going to explain how the procedure works and why hip replacement surgery in general is an excellent procedure. And if you need it, you absolutely don't need to worry about having one, and how my patients recover so quickly. They're walking the same day of surgery, and most either go home the same day or the next day safely. But more to the point, I'm going to explain why 80% to 90% of my patients that see me with hip arthritis don't ever need surgery. They are managed with our biology first, surgery last approach, which keeps many patients away from the operating theatre and back doing lots of activities they enjoy without having surgery. So my name is Dr Arj Imbuldeniya. I'm a consultant knee and hip surgeon based at the Lanserhof clinic in Mayfair and the Cromwell hospital. I also still work in the NHS in London, and my whole practice is built around a concept that I've been practicing called OrthoLongevity. I've realised over a decade of being a consultant surgeon, having treated thousands of patients now, that actually if we can keep patients away from surgery, which is the thing I've trained in for decades, that's actually a better outcome for them. It's safer, it's not invasive. There are natural measures that you can take to reduce the need for you to have surgery. And it's what we call a biology first, surgery last approach. And it works by us looking after you together, the orthopedic surgeon, the physiotherapist, the osteopath, the nutritionist, the strength and conditioning coach, the sports medicine doctor, and the functional medicine and lifestyle medicine practitioners. And a lot of our procedures are really good, and sometimes actually surgery is the best option, but it's important that you see the right person who's able to take you through all your options and not withhold any options. So what you don't want is to not have surgery for many, many years, if that would have been the best option for you. And likewise, you don't want to be having surgery or being told you need surgery when actually there are other options that haven't been put to you. So in this video, I'm going to cover what hip arthritis is, why hip joints may wear out and what that actually means, why the right approach for you doesn't just depend on scans or x-rays, it depends on the entire picture, including your symptoms, the activities you want to do, the biology, which means your general fitness, your general health, how active or inactive you are, what your weight is like, how much muscle you have on you, whether you get to the gym and do strength training, whether you're positive, whether you've got depression, whether you're stressed. All of these things really affect our pain, inflammation in our body. And we're getting better at understanding now that we're complex human beings, and actually treating something like hip osteoarthritis or knee osteoarthritis is not just straightforward. And it doesn't just mean, you have to have an injection or you have to have an operation or you just have to see a physio. There's more to it. The surgical approach for hip replacement kind of matters, but also doesn't. Why hip replacement in general is a very good operation. I perform hip replacements in two specific ways. I can actually do it three ways, though one of the ways I learned many years ago I don't think is that good for hip replacement, but certainly the other two approaches are good, and they both have slightly different benefits and slightly different risks. And why am I so interested in practicing holistically? Well, I wasn't necessarily trained that way, but as someone who is approaching 50 next year, I now have 4 children. The youngest 2 are 6 months old currently, and we're going to have a 3-year-old next week, alongside my teenagers, the eldest of which is hoping to go to university in a few months' time. I've realised that when I lost my father, he was basically 50, and my grandfather also died age 42. And there's a history really of men in our family kind of dying quite early, I would say. So that really weighs heavily on me. And I've become really interested and passionate about fitness, longevity, trying to do our bit to try and keep us on this planet, living our lives as long as possible, enjoying ourselves, staying active and healthy, and being there for all the people around us that we care about and care about us. And so all the advice I give you, I basically follow myself. So I'm absolutely practicing what I preach. And though I feel I'm a good technician and a really good surgeon, and I'm just getting better and better as the years go on, I've never had surgery myself. Though I've performed thousands of procedures now, And on that basis, I don't really want you to have surgery unless you really have to. And if you do, we're going to do the best job possible for you with the latest techniques and technology and equipment. A quick medical disclaimer as always for these videos. The video is general education. It can't really be personalized medical advice. And though I'd love to treat you and be your doctor, I'm not at the moment. You're watching a YouTube video. Please understand that the video is really to help you be better informed, give you the skills and knowledge that you need. So when you see your own clinician, whether that's your family doctor or an orthopedic surgeon or a physio, an osteopath or a sports med doctor or any of the really qualified MSK or musculoskeletal health professionals, you can see you're in a better place to have a really good two-way discussion with them about your options, basically. So why do hips wear out and what actually causes you the pain and stiffness? So the hip, you may have heard, is a ball and socket joint. What that means is you've got the long bone in your thigh, and at the top of that is a round, normally spherical part of the bone that we call the head of the femur. In some patients, it's not totally round, so it should really be a bit like a snooker ball or a billiard ball or a pool ball, depending on what sport you play. In some people, it's a little bit less even. It's a little bit more oval shaped, like a rugby ball. Or it can, with age and as it wears down, it can start to get a bit knobbly and become a bit more like a rock. And that's not ideal because it needs to sit in a socket, which again normally matches the ball or the femur head really well. In some people, again, where they have certain conditions like femoroacetabular impingement or hip dysplasia, and the bits don't match quite as well. So someone may have a ball that isn't quite shaped like a ball, and some patients may have a socket that's really, really too deep or actually really, really shallow, and then the bits don't fit. And you can get loading between the bones and the squidgy, rubbery lining on top of the bones, which is called cartilage, and you can get sort of uneven wear. So that's one of the reasons why your hip may start to hurt, and one of the reasons why you may get osteoarthritis. Osteoarthritis is just a medical term to mean that the cartilage on the top of the bone, or the padding that I mentioned, which is normally on the top of bones where bones meet another bone, so that's called a joint. So this cartilage is really terrible at regenerating or repairing itself. And when it starts to wear down because of too much pressure or genetic factors or injury or damage or even surgery sometimes, or all of the above, or infection, then as the cartilage wears down, you can get pain because the bone that's unprotected below the worn away or thinned or cracked cartilage can start to feel a lot of pressure. And then you can get inflammation in your joint where basically the lining of the joint can start to swell a bit. And that is something that really causes pain. Lots of toxins and chemicals are released into the joint. They're really painful. And rather worryingly, sometimes chemicals are released, which causes a cyclical process where more cartilage then starts to get broken down because some of the toxins are really bad for cartilage. So it's kind of a vicious cycle, and you end up just getting a really swollen, painful joint. You can get a lot of stiffness because your joint tries to respond and help itself. Your body can sometimes make these bony spurs that we call osteophytes, and they're sharp, fragile bits of bone that can be formed in your hip joint or your knee joint. And your body's trying to help. They actually can hurt you because, you can feel these sharp bits of bone rubbing or impinging on structures in your hip or knee. And in your hip in particular, you've got lots of muscle and tendon all around the hip. And some of these sharp bits of bone can rub or catch and cause discomfort. And that causes more swelling. So it's a real terrible way to be. But actually, we always thought that what really mattered was how much cartilage you'd lost and whether the changes were sort of bone on bone, which is what you may hear a lot. But it doesn't matter as much as you think. And that's what I've realized, and lots of my peers have realized over the years. You can have a fairly worn out hip joint, but it doesn't have to bother you that much. There are lots of patients who have fairly advanced osteoarthritis on their x-rays, but actually function pretty well. And likewise, I see lots of patients who have like moderate changes of osteoarthritis and are absolutely disabled and debilitated. And that's where the other aspects of your general health come in. If you're a really good weight, if your muscles around your hip and your core, like your abdomen and your back, are really strong, and your thighs, and if you're really positive, you've got a positive attitude, you've got fortunate genetics in that there's not much joint problems, in your family, or history of inflammatory arthritis or rheumatism, if you've not had any significant injuries or surgeries or deep infections in the joint, and if you have a really good diet, like a healthy anti-inflammatory diet full of lots of greens, vegetables, oily fish, nuts, pulses, legumes, not much fried food. And if you don't really drink much alcohol or you're teetotal, then, you can feel really, really good, even though your hip MRI scans or your hip x-rays look terrible. So we've learned that, we're more than our x-rays, and also our x-rays and scans don't necessarily show pain. They just show structure. So it's really important that you don't feel too downbeat if you've been told by your healthcare professional that you have arthritis or a worn out hip. I see tons of patients every week who've been told they have arthritis, and when I look at them and I see their scans, I have to politely disagree that they don't, or they only have a little bit. And it's really important you're not pigeonholed too early, and that you're also not taking lots and lots of prescription medication early and becoming dependent on it. What you need to do is see someone who knows what they're talking about and is really experienced and can help you get active again and happy. And you only need interventions like injections or hip replacements if you're really, really struggling, and then we need to take you to the next level. So I'll always try and do injection therapy for patients who are not able to do their exercise or are really struggling and miserable. And if the injection therapies only work transiently or don't really work at all, and they've got significantly bad changes on their scans and x-rays, then we'll talk about hip replacement, and then we'll decide which type of hip replacement, whether it'll be the Röttinger anterior approach or the mini posterior approach. We can talk about that shortly. So I talked about exercises, and one of the most common things people want me to do in the consultation, though I'm not a physiotherapist or a strength and conditioning coach or a personal trainer, is show them what exercises I do in the gym. So I've made a video that you can watch on this channel about what exercises that you do, or that I do basically. I do strongly feel, having worked with, really hundreds of physiotherapists and quite a lot of really high quality strength and conditioning coaches, and having looked at a lot of the research myself, I would say the best thing to do in the gym is to go on the machines, so the resistance machines in the gym. Though you can get really strong doing yoga and Pilates and doing resistance work at home with bands or with kettlebells or dumbbells, in my humble opinion, I absolutely think for legs, for strengthening your thighs, your hips, your calves, strengthening all the muscles around your hips and knees, you have to be in a gym, because you need a lot of resistance. It doesn't matter if you think you're not strong enough, you're not fit enough, you're human. And by definition, if you're a walking human, you will have really big muscles in your legs that are actually a lot more powerful than you think. So to get adequate resistance, to grow your muscles or induce what we call muscle hypertrophy, you need to really be in that gym, pushing your legs in various directions, whether it's pushing your legs apart or having your legs apart and squeezing them together, or pushing your legs away like a leg press, or pushing your toes down like a ballerina to go on tiptoes. You need resistance so that it's difficult to do about 6 repetitions of each exercise. So I would always recommend doing 6 repetitions 3 or 4 times. And every time you do 6, you want to have a break for 1 to 2 minutes. You then want to do another 6 of the same exercise, have a break, and then do a final 6. I've actually recently started doing 4 sets instead of 3 when I've got more time, just because I'm getting really into the exercise. I'm starting to enjoy it now. And I don't always get to go to the gym as much as I want. I normally only do legs once a week. I do upper body also now once a week, which isn't that important for hip or knee pain at all, but it's just something that I do. And then I normally do some jogging or cardio sessions once or twice a week. And that's often all I can manage as a busy orthopedic surgeon with a private practice and NHS practice. I'm also building some health tech applications to try and help patients get all the answers they need if they have hip or knee pain. So, and I also have 4 children, a dog and 2 cats. So I really struggle to do more than like 3 exercise sessions a week. And if I can even do 2, I'm happy with that. And I think it's really important with you that consistency is really important, and building new habits. You absolutely mustn't put pressure on yourself to get to the gym or do exercise too much, especially if you're really busy at home or at work, because you'll just feel really depressed when you can't make those sessions. So set the bar low. If you're someone that doesn't go to the gym much, or you've never been to the gym, my ask would be that you go to the gym once a week. You put it in your diary, and you have like 1 hour or maybe 90 minutes that you set aside for the gym, and that is it. And if you can do that, if you start doing that after 3 months or 6 months, you're going to see so much gains. And then, okay, look, if you get really into it and you've got more time, of course, you can go 2 or 3 times. I wouldn't go more than 3 times a day. If you're doing resistance work, pushing and pulling your body in various different directions against resistance, your body needs a lot of time to recover and rebuild. That's the key. And sometimes when I see patients who are super active, they're actually not resting enough. They're doing weights or going to the gym or running 4 or 5 times a week, and it's probably a bit too much. So rest days are really important, especially if you're getting old like me and you're approaching 50, or you're basically, I would say, over 35. I think you've got to start resting and looking after yourself. You actually perform better if you rest, have really good nutrition, sleep well, at least 7 hours good sleep a night, if you can get it. And it's really hard for me at the moment because we've got a 6-month-old and an almost 3-year-old, both of whom don't always sleep as much as I would like to. And so it's tough, right? And we live in the real world, but these things can really help you. And strength training, I guarantee, is the best medicine you can get. It's the best longevity medicine you're going to ever be prescribed, better than anything else you can think of. So just to recap in terms of exercises for your hips, I would say all exercises for your legs are important for your hips. So that would be hip abduction, that's pushing your legs away, hip adduction, pushing them back together, leg press, which is kind of like a squat, but much safer because you're sitting in a seat and pushing your legs away. And I always like double leg exercises. So single leg is really popular with physiotherapists, and of course they are the experts. But for me, I would do double leg. You want to get both your legs strong, and single leg is probably better if you're more advanced or if you are recovering from an injury on one leg. That's fine, but I still prefer double leg. And also add in leg extension, which is where you try and straighten your knee against resistance. Hamstring curls, where you normally lie on your tummy and bend your knee, and then you can feel some force behind your thigh or some resistance behind your thigh. Calf raises, where you stand on tiptoes with weights, or I normally sit on the leg pressure machine and push my feet away against resistance. That works your calves. And then another good one that I really like is called a deadlift. That's sometimes technically a bit challenging to do when you're a beginner, but I show you how to do it in the video that I explained on the channel. And also there's lots of other really well qualified trainers and physiotherapists and strength coaches you can watch and show you how to do a proper deadlift. But that's a really good exercise that really helps your glute max, which is the big muscle in your bum, your hamstring muscles at the back of your thigh, and also your lower back. So I would do that if you've got hip pain at least once a week. You can also augment it with some stretching. Yoga is really good. I used to do it, I've stopped doing it, but I might start doing it again. It's just really good for your mental health, your breathing, your stretching, your flexibility. And it gives you a different type of strength. For joint pain, whether it's hip or knee osteoarthritis, it's super important that you build muscle. And that's why I want you to do less reps, but slightly higher weights, slightly higher resistance. The other type of muscle fiber you've got, because there's 2 types of muscle fiber, is for stamina and endurance. So if you're holding a pose in yoga, like a warrior 1 pose, where you're in a bit of a lunge and you're holding it, that's different to becoming really, really strong, but it's a different type of strength. It's the strength to hold a lighter amount of weight, but for a longer time. That's not as important to alleviate joint pain, but it's a really good thing to do. And the reason I like yoga is it includes stretching, which is important. I hate stretching. I'm not very stretchy, but stretching is really important. And I've got really tight hips, especially in the groins, and quite weak adductor and groin muscles as well. So you've got to know your body and what you're good at and what you're bad at. And it's important that you work on the things that you're bad at, and you don't just go to the gym and do the exercises you really like doing or the exercises that you're good at. It's like, be really even. Also cardio is good. I think running is great. People are always told not to run. It wears out your joints. That's not true at all. Running is good for you, but you want to run on strong legs. So first, spend 2 or 3 months getting your legs strong, and then fine, if you're getting stronger and your numbers are getting better, you can start jogging. I'd always start jogging on a treadmill first because it's softer and it's even. It's quite boring though. I like running outdoors. So, once you're happy and the weather's good, of course, run outdoors, but just be careful again. You don't hurt yourself running on uneven ground. Try and run on the flattest ground you can, like a road or a running track. I think running off-road, like in a forest, is really nice, but it's really uneven and quite dangerous. You've got to be switched on and, keep looking where you're going, but that's fine as well. In terms of your gym exercises, I would document them. I used to document them just on a pen and a pad because that's how old I am, but I would now use an app. So I have an app that I use called Gymverse. I'm not sponsored by them or anything. It's just an app that I found that's really useful. I suspect there's loads of apps like that. Also, if you're really into coding and AI like I am, you can probably make something now that you can use with no coding tools that are out there. So it's really important that you document what you did. So if you're doing a leg press, like how much weight how many reps, how many sets. And then next week when you go back, you can kind of see what you used to do and then see, if you want to beat it and do a little bit more weight. Or sometimes, it's really normal that you may not feel as strong as you used to, and then it's totally fine to just dial the weights down. You're not always going to improve every week. Again, we're just humans. Sometimes we have really great weeks. Sometimes we don't have very good weeks because we're tired or we don't feel up to it. And actually, sometimes when I haven't been to the gym for a few weeks, because I've been really busy and I think I'm just going to be terrible, I'm actually really strong because I had so much rest. So our progress is up and down, but overall, if you keep going, it's going to just get better and better. So overall, you've got to compound your improvement and feel better. So what is a hip replacement and what happens with a hip replacement? And also, what's a hip resurfacing? So hip resurfacing, I think theoretically is an excellent operation, and in practice sounded like a good operation, but unfortunately wasn't about 10 to 20 years ago, because the parts were both made out of metal. It's where the ball, the head of the femur, isn't actually taken off. So in a hip replacement, it's taken off. And this is more bone conserving. So the worn away cartilage is removed and then a sort of metal cap is placed on the bone. The problem was the metal cap and then the new metal socket, if they were placed not exactly accurately, and as humans, we can't always be perfect. If the orientation was a little bit out by a few degrees, you'd get uneven wearing of the metal on metal, and you get this debris that was released into the hip and into the bloodstream. And that was really catastrophic for patients. It was poisonous. It would kill muscle. It would melt the bone to a degree, and the implants would come loose. And also the cobalt and chromium toxin would leak into the blood. So that was a real disaster for the orthopedic community globally. Some people actually did really well, and we realized that they were normally male patients who had slightly bigger bones. And also if you had your surgery done by a surgeon who's really, really experienced in hip resurfacing. It sort of died. It's made a comeback now. So we've got some really good colleagues who've designed hip resurfacing implants with ceramic bits, and I think that's really, really promising. I don't do hip resurfacing. I think the operation is good, but I think the approach is a little bit invasive at the moment, or certainly the way I would do it, because you've got your ball and socket joint like that. You really have to move the ball joint out of the way to see the socket, to put a new socket in. And in hip replacement, it's really easy because you take off the ball basically, and then you can just see the socket. But in the resurfacing, because you're keeping the ball there, you have to do what's called releases, which is a nice surgical euphemism for basically cutting things. And I think you have to release a bit and move the femur out of the way. I think it's a little bit invasive at the moment. There may be a really non-invasive way of doing it, but I don't know it yet. So I'm always looking to learn new things and keep training. So I'll let you know if that changes. For now, though, I prefer hip replacement surgery because you do take off the ball, but it's such a good operation. You put a new part in, new socket, link them together, test that the hip is stable, it doesn't dislocate, test that the parts fit really well, and that you haven't made the patient's leg too long or too short, which is something that can happen, and that you haven't made the hip too wide or too narrow. And when you're happy, put the proper parts in, sew up the patient, wake them up and watch them, be really happy with their new hip replacement. So hip replacement surgery is basically probably slightly more aggressive than hip resurfacing in that it's a bit less bone conserving. But I would say, with the anterior technique, like the Röttinger approach, and even the historic posterior approach, which a lot of us do now, much less invasive than it was done decades ago, it's amazing. And I love doing it. I still do a lot of knee surgery, a lot of knee cartilage surgery, repairing meniscus, ligament surgery, and I do some replacement surgery as well. But I love doing hip replacement surgery because it just works so well. And I love seeing, my patients being really happy. And, after about a fortnight, just almost being back to normal, which is amazing because our techniques have got so much better. I would say the implants are better, but also our anaesthetists are really good as well. And our physiotherapists and our nursing staff, who all, have a huge part to play in your recovery if you're having hip replacement surgery. So what is the Röttinger approach and why did I start learning to do it? So I was doing the posterior approach, or the mini posterior approach. I learned it in Sydney, Australia at the Mayfair Hospital, with some of Australia's best hip replacement surgeons. I also had really good training in London from some of our top hip replacement surgeons here. And they're all kind of doing it the same way and then slightly evolving it to be less invasive. You sort of go in through the back of the hip. You do have to cut a few really small tendons at the back of the hip that are called short external rotators. Normally the muscles that we cut are called, or the tendons that we cut are called gemellus superior and inferior, obturator internus. Piriformis used to be cut, but most of us now do the surgery bearing the piriformis muscle. And many of us can also leave another muscle called quadratus femoris, the traditional version of the posterior approach, that was also cut. Regardless of whether 3 of these small muscles are cut or all 5 are removed off the bone, they're all normally sutured back on through the bone, so they're absolutely solid after the surgery. The main, I think, downside of the posterior approach is that you probably have a slightly more unstable hip afterwards, so the hip could dislocate out the back. The way surgeons mitigate this normally is to use a much bigger ball. So traditionally the ball that we'd replace would be smaller than your human one, but now we tend to upsize it so it's bigger. That could be with something called a dual mobility hip replacement, where we have a little ball inside a big ball to stop them wearing out. And that can be super successful, but overall I would say it is a bit more unstable, and dislocation is a worry even for me. Otherwise, the view from a posterior approach is exceptional. It's a really easy approach to do, I find. But I can't really do it faster than about 1 hour. It takes me about 60 minutes. And I'm not obviously a surgeon who wants to rush. I wouldn't want to rush your surgery, but I also don't want to be so long in there that it's unsafe. So if it was a straightforward case in a very slim patient, normally 60 minutes is how long it would take me to get safely into the hip, remove the old arthritic hip, put in the new parts, trial them out, and then put the real parts in, and then sort of wash out the hip with antiseptic, and then close the hip and repair those muscles back. So that takes me about 60 minutes. And, in the NHS, when I've got such a long waiting list, it's about 1 to 2 years now for patients to have surgery from me. If they're on my waiting list, and it often takes them about a year or more to just get to see someone like me in clinic. It's really important that we do more surgeries safely and well in the NHS. And the Röttinger approach was explained to me as this innovative approach that cuts no muscle. And the surgeons in Munich apparently can do the surgery in like 20 minutes. And I absolutely didn't believe that. I just couldn't even fathom this. And then I remember I went to see one of the top surgeons at the OCM, which is the centre in Munich where Professor Röttinger worked and still works, where he devised this over 25 years ago. And, I saw a surgeon called Professor Huber, and it was unbelievable. He just did a hip in 20 minutes in front of my eyes and then proceeded to do about 5 more that morning. So to put it into context, in most NHS hospitals, we do sort of 3, certainly in London, we do 3 to 4 hip replacements a day. And these guys were doing like 6 in a morning, So the productivity was really good. Obviously the team was very slick, like a well-oiled machine, like a Formula 1 pit crew. But I knew that if I could get good at this approach, and it's minimally invasive, so patients didn't really need much anaesthetic. They would just be walking quite soon after the surgery, a few hours afterwards, and fairly pain-free, and 1 or 2 weeks later, kind of almost back to normal. So I felt if I could replicate this in the NHS, I could get more cases done, get through the waiting list. And of course, it seemed like it was even less invasive than the really good posterior approach which I was using. So I had to try and learn it. And it's really hard when you're a consultant surgeon to suddenly become really terrible at doing something again, because the whole thing is just different. It's not what we're used to in the UK. It's actually based on a British surgical approach that goes through the front of the hip called the Watson-Jones approach, which was devised in 1936. And it's an approach where you go between muscles. So where the posterior approach kind of goes through the large gluteus maximus muscle, so we sort of just go through that. And then we obviously have to detach some small tendons at the back of the hip that we repair. The Röttinger anterior approach goes between 2 muscles. So that's the gluteus medius, which is a very important muscle on the side of your hip. And it's really important with hip replacement surgery that your surgeon ideally doesn't interfere with that or remove that muscle and repair it, because it's the most important muscle for walking and climbing things. So we just go in front of that muscle and behind the next muscle next door to it, which is called the tensor fascia lata. And so that's a small muscle at the front of the hip. So we just go in the gap. I have to say, wasn't that easy to find initially. It looks easy to find in a textbook, but not that easy in real life. So that's why I practiced with cadaver training initially. So we would go to labs where people had kindly donated their bodies for surgeons to basically train on. So practice in the lab, and then I got the hang of it. But that's really easy because cadavers don't bleed basically. And then when you have to do the procedure on real patients, obviously it's quite different. we had to go through, for governance obviously, and for safety, we went through a new interventional procedures board at my NHS hospital where we had to sort of explain the procedure and the evidence behind it and what the benefits would be and also the risks. And then I did the procedure with actually surgeons from Germany very kindly flying in to the UK on 2 separate occasions to do the cases with me, to kind of hold my hand basically to make sure that I was doing it okay. And then after doing that, I continued to do it and get better, but it was a struggle. The other thing was, none of my team had seen the approach in Germany. So it probably would have been a good idea for me to take some of them there. But the problem in the NHS in particular is sometimes we don't always get regular staff. So it's difficult to have a set team. I think some units do that better than others. But certainly in one of the private hospitals I work in called the Cromwell Hospital, so that's in London, we've got a very stable, good team and they're really well trained on the technique. So privately, I tend to do the surgery there because the team know exactly what they're doing and they're great. And in the NHS now, our team's getting really good at doing it. So it's been tough, but I think it's definitely been worth it. It's an approach we can use in all patients, including really heavy patients, because actually, if you're quite heavy, you're carrying a lot of fat around your buttocks or your stomach, the approach kind of goes in through the front and side, I guess. So it's a bit away from your tummy, but it's also a bit away from your arm or your buttocks where you carry a lot of fat. The procedure is also done with you on your side. So for the team, it's really easy for them, for the anaesthetist and for the scrub team, because the patient's on the side, positioned exactly like a typical posterior approach, or another common way of doing the surgery called a hard-hinge lateral approach, which I don't really like doing, but the patient's in the same position. So that really doesn't disrupt the rest of the team. There's another anterior approach called the direct anterior. And theoretically, again, that's a really good approach. It goes to the front between 2 muscles. But I always found that can be a bit challenging for the team because the patient is operated on lying on their back. So it's quite a different position for the anaesthetist and the scrub team. And you sometimes need a special table and some special equipment for that. And sometimes you also need X-ray during the procedure. So I felt this kind of has the benefits of the direct anterior, but it's kind of technically easier for everyone. It doesn't need X-ray, it doesn't need a special table. And the setup's kind of the same as a posterior. So if you had to change approach, you're in the right position. So I thought it's great. It's really unusual that it's hardly done at all outside of Germany or Munich in particular. And I don't believe anyone's really doing it regularly, as far as I'm aware, in the UK, except me. Though I'm sure that's changing. And so it's great. I'm getting better at it now. And my goal really is to train more surgeons. In terms of anaesthetic technique, you can either have a general anaesthetic where you have a small injection and you fall asleep, but the anaesthetist has to put a tube down your throat and attach you to a respirator machine that helps you breathe. We don't really like doing that for hip and knee replacements. Ideally now, we prefer you to have a spinal anaesthetic, which sounds really scary, but actually it's a really small needle that just goes into the back. And the needle goes in and about 2 mils of anaesthetic is injected just around the spinal cord, makes your legs numb within about 5 minutes. And that can last up to about 3 hours. So comfortable time for this sort of surgery. And then patients really worry that they're going to be awake, but they're not normally, unless you want to be awake talking to us. But most patients want to not know what's going on. So you have a small injection or a small sedative. So you have a little nap and you're snoozing away basically whilst we do surgery. Some patients actually like to stay awake and talk to us, and some will stay awake and they may watch something with their headphones. They may watch something on their iPad if they wish. So that's what I'd recommend for these types of surgeries, because there's no pain, and after surgery, you kind of wake up really fresh, like you've woken up from a nap. There's no sickness, nausea, or vomiting, and no pain. You just don't have any power in your legs for a little bit, so you have to wait a little bit to start walking. But normally, about 1.5 hours, 2 hours after surgery, you're safe to sort of sit up in a chair and then start walking. Sometimes with spinal anaesthetic, you can feel a bit dizzy. You get a bit of a low blood pressure, like a head rush when you get up. But that's fine, that's normal. If that happens, we sit you back down again. You need lots of food and water and drink. You've got to take on lots of protein and carbohydrate to kind of build up. And then a bit later in the day, you can start walking again. With my patients, they're pretty much home, all of them home, I'd say, the next day, and some go home the same day if they wish. Certainly, again, that's really popular in the NHS, where we're struggling for beds to kind of do these procedures if we can as day surgery. In private practice, I've noticed that patients, are paying a lot of money for their surgery, or their insurance are paying. So they're quite happy to stay a bit longer. And also the hospitals are quite nice. So I think they quite like the nice food and menus that they get and the care they get from the staff. Normally for my patients after hip replacement, whether it's Röttinger or mini posterior, you have a small scar. It's normally about 8 to 10 centimeters. It's going to be bigger if you're bigger. So if you're carrying a lot of weight or a lot of fat around your hips, then the skull has to be bigger because we need to be able to see what we're doing. But generally, we try and keep it as small as we can, so it's safe that we can see and do the job properly, but it's not too big. And we sew up with stitch that's dissolvable, so no stitches need to come out. But you normally have a sticky dressing on your hip, and you want to keep your hip dry if you can for the first 2 weeks. You can shower. Sometimes I ask patients to put cling film or some kind of plastic over the dressing as a second waterproof barrier, but normally the dressings are waterproof. But we don't want you to go in a hot tub or a swimming pool or hydrotherapy for the first 2 weeks till I know the wound is healed. So I'm a bit old-fashioned like that. Some surgeons are happy for you to go in a pool straight away, but I'm really worried about infections, so I'd rather you didn't. Normally, I send you home with 2 weeks worth of painkillers, but again, after Röttinger hip replacement in particular, patients don't need much in the way of painkillers, maybe some paracetamol and an anti-inflammatory like ibuprofen for a week or 2 max. They don't really need anything too much stronger like codeine or morphine, which is sometimes what you need with other approaches to hip replacement. And certainly if you're having a knee replacement, normally that can be quite painful. So, they're definitely different operations. Knee replacements and hip replacements are quite different. And I'm going to do more videos on knee replacements in the next few weeks just to explain that for you. Otherwise, in terms of risks, though it's an excellent procedure and it's probably the second best procedure ever invented after cataract surgery, there are risks, and probably the risk of something going wrong if you have a hip replacement, whether it's Röttinger or mini posterior or direct anterior, is about 1% of something going wrong. So that could include the hip dislocates, there's some sort of nerve injury, so you feel numbness and pain that you shouldn't. The parts that we put in could come loose early on. So it's like bricks in a house, like one of the bricks coming loose. Sometimes the hip implants can come loose when they shouldn't. The hip implants could wear away, though that's very rare nowadays because they're so durable. But they normally wear away after about 25, 35 years. I would say they don't really tend to wear away within 10 or 15 years anymore, which is what we used to tell patients. Especially if you've got ceramic parts in, they're very durable. In terms of the parts I use, I tend to, the bits that stick into the bone. So there's a bit that sticks to your femur bone or your thigh bone, and a bit that sticks into your pelvis bone or your acetabulum. They're made out of metal. They're normally a titanium type alloy because titanium is a very relatively soft metal, similar in bendiness to your bones. That's really good. You don't want anything too hard because otherwise the bone kind of gets really lazy and gets thinner. And then the bits that touch, so the ball bit and the socket bit, normally they're not metal because obviously we had that disaster with hip resurfacings. We don't like to use metal bits normally that touch each other. So we don't want the bearing surfaces to be metal. So normally the ball is ceramic when I do the hip, and the socket used to be ceramic. There's a little liner inside, but it's normally now a piece of bouncy plastic called ultra high molecular weight polyethylene. So that's a special plastic that acts like a kind of a cartridge, I guess. So I quite like what's called a hard surface on a soft surface. So there's a bit of give in your hip when you're doing high level activities. All my patients get back to full activities. I tend to operate a lot on younger patients for hip replacements. I'm not sure why, but that's just how it happened when I became a consultant. So most of my hip replacement patients are between the ages of about 40 and 65, I would say. And they're super active people. So they've got back to football, martial arts, marathon running. One of them was a cage fighter and we did both his hips. So hip replacements weren't invented for this sort of high level activity, but obviously we've had to catch up because patients are super active nowadays. They're different to how they were in the 1960s and 70s, where someone who was 60 years old, was a lot more sedentary than now. So it seems okay, we've not had any disasters because of these activities. So if you want to get back to all activities and that's your aim, then I'm happy for you to go for it. Your own surgeon might feel differently, so make sure you talk to them about that. So hopefully that's answered all your questions about the Röttinger hip approach and also generally about total hip replacement in general. If you've got any more questions, put them in the comments below and I'll answer them. I try and answer all the questions actually for my videos at present, and I've been able to do that thus far. Also, if you've got more questions, let me know, because if there's a common theme, if there's something I missed out with the topic of hip replacement in particular, I'm more than happy to make more videos. Otherwise, take-home message would be, if you've got hip osteoarthritis or a stiff, painful hip, you don't have to suffer with it. See a team or an expert in hips to understand what you need. Just know that the scan doesn't equal the treatment. So if you've got a really worn out hip or a moderately worn out hip, or your hip's not worn out at all, but you've got a little bit of early cartilage damage, you're more complex than that. So your clinician or your doctor or your physio, whoever it is, needs to take into account everything about you, like who you are, what you want to be doing, what your medical history is like, what your personality is like, how heavy you are in terms of how much weight you're carrying. whether you do any gym work, what your diet's like, what your stress is like, the whole thing. And, you know, you're going to do a lot better if all of those factors are addressed. That's something called lifestyle medicine, which I'm now learning and becoming an expert in as well, because it's super important. And I'm realizing this is what's transforming the care my patients get. If you do end up needing a hip replacement though, don't worry, it's a really good procedure. And I wouldn't also worry too much about the approach. Though I've shifted a lot more now to the Röttinger approach, I still think the posterior approach is amazing. And I've got really good colleagues who do the surgery well with the direct anterior approach. I'm probably not that keen on the modified hard hinge approach. That's the approach for the side of the hip where the really important gluteus medius muscle is sort of taken off and then repaired. But having said that, you know, these patients actually, they limp a bit for the first 3 or 4 months. By about a year, they're doing really well as well. So overall, you know, if you need a hip replacement, don't worry about it at all. Just make sure you do your research, make sure you're comfortable with your surgeon and you ask him or her all the questions you need. And otherwise, that's it for the time being. Have a great rest of your day and thanks so much for watching. It means a lot.